other, and your questions and your queries are very pertinent to me because they sort of give us an insight into the whole procedure. I'm going to talk on endometrial preparation, as Sejeshri said, for frozen embryo transfer. Now, I'm going to tell you the most physiological way forward to frozen embryo transfer cycles. You all understand that we all know from our physiology that endometrial cycle consists of a proliferative phase by the effect of...
Huh? Kindly mute yourself, everyone.
बस नहीं बस इतना ही बस
Dr. Varsha, kindly mute yourself, please.
And the second phase is under the effect of progesterone, which is known as secretory phase. Having said that, in both the phases, there are a lot of factors which are upregulated and downregulated. And why is this done? Because the whole purpose of endometrial growth, the estrogen phase, the progesterone phase, the up and down regulation of all the factors is all targeted towards achieving only one ultimate function, which is implantation of embryo. And this is how human race can always continue. Implantation of embryo can only take place in a very precise ovarian estrogen progesterone derived phenomena, which creates the window of implantation. Like it has to be primed with estrogen, and then by the effect of progesterone, at one point of time, all the receptors open up for implantation. That time is known as window of implantation. It is a self-limited period of endometrial receptivity spanning between day 9 and 23 of a 28-day menstrual cycle. It could be for 24 hours, 48 hours, or even more in some patients. Now, where do we think that conditions which do not allow fresh embryo transfer, we all do IVF, but there are certain conditions where we think that fresh embryo transfer, I don't want to do, because either these indications safeguard the woman's health or they optimize the chances of pregnancy for the patient. These are following conditions. One is risk of OHSS. If there's underlying PCOS, HCG, high estradiol levels, then we don't like to go ahead with transfer in that cycle. Progesterone elevation, stronger and longer stimulation for IVF often leads to a progesterone rise on the day of HCG. That means the endometrium is exposed to higher progesterone levels 2 days earlier than it should be from the day of OCR. And hence the endometrium is advanced. Your endometrium is exposed to progesterone 7 days when you're going to transfer a 5-day embryo, or for 5 days when you're going to transfer a day 3 embryo. And hence in these cycles where progesterone gets elevated and we've given long and strong stimulations, it is good to do a progesterone level. If it is elevated, it is best to freeze these embryos. Inappropriate endometrium, you suddenly feel the endometrium has become very thick, or it is still very thin, whereas in natural cycle, it looked good. So you do not like to transfer, or you suddenly see a polyp on the day of pickup, or you see patient is bleeding, there's fluid in the cavity, which is significant. In these conditions also, you would like to freeze your embryos. And the last is if the patient has any medical or surgical condition, emergency arises just before controlled ovarian stimulation or on the day of OCR, you just take out the eggs and then first treat the patient to become all right. And later on, we can transfer when the patient is fine. Apart from this, there are some indications which warrant only frozen embryo transfer, conditions which do not allow you a fresh transfer. What are these? PGT embryos, where you have to do a biopsy, you have to freeze these embryos to get the reports. Then in non-synchronized donor-recipient cycles, embryos or oocytes frozen for fertility preservation, you will have to thaw them and then do them in a, do transfer as a frozen embryo cycle. RIF, where you find there is a displaced window of implantation, which we often see by the test called ERA, which is endometrial receptivity array. And even a previous ectopic in IVF cycle calls for a frozen embryo transfer only, because it has been now very clearly demonstrated that frozen embryo transfer cycles have the lowest chance of ectopic, which is less than 0.9, and it is a blastocyst transfer, which further lowers the ectopic chance in a patient. Having said that, you all know that the building stone for architecture of the proliferative phase is rising estradiol. And where do we get endogenous estrogen from? From natural ovulatory cycles. Natural ovulatory cycles, the estrogen will rise in the estrogen phase. So natural cycle is the best option in women who are ovulating regularly. But there are some women who do not ovulate regularly, and where you may feel that, I want to stimulate the cycle with ovulation inducers so that I make her ovulate by medicines and use that endogenous estrogen for building up her endometrium. But then both these cycles require intense monitoring in the peri-ovulatory period. And intense monitoring means if she has a 28-day cycle, you would start monitoring from generally day 11 or 12, and you would need a daily monitoring of her hormones, but not ultrasound. And there is a high incidence of cycle cancellation. You don't do a hormone test for 2 days and you suddenly do it on day 12 and you find her progesterone is already 2 or 3. So that means she's ovulated before that. And hence you will have to cancel her cycle, or if you still go ahead, then you would be either too early or too late for embryo transfer. So having said that, monitoring of natural or modified ovulatory cycles or stimulated cycle is all done in the same way. That means a baseline ultrasound follicle monitoring to see the endometrium is very important, and a serum estradiol, progesterone, and LH levels baseline are to be done on day 2 or 3 whenever you want to. We don't give anything else apart from folic acid to these patients. Second ultrasound straight away will come on day 11 or 12 in patients who have regular 26 to 28-day cycle. And we do the same 3 blood tests: estradiol, progesterone, and LH. If estradiol is 50 and you find that progesterone is not elevated and LH is also near the baseline, that means till day 11, there has been hardly any follicular development and hardly any steroid production from this follicle. These are cases where you have to be cautious because there is a high cancellation rate here if you do not monitor closely. Then we come to follow-up. Once you've done it on day 11, 12, then after that you do a regular follow-up. You do it daily or alternate day by blood test alone according to reports. So you don't need to call her for ultrasound every day. Just do the blood test alone. You can even do alternate day. When do you do daily? If LH is twice the baseline, say LH was 3 or 4 and it has reached 8 or 10, that means it has started to rise and it will surge in the next 2 or 3 days. And if the estradiol levels are more than 100 picogram, we prefer to do a hormone monitoring daily. LH and progesterone only is required. Now estrogen can be left out because we know that this is a ovulatory follicle, because estrogen doesn't come up to 100 on day 11, 12 if it was 20, 30, 40 in the baseline. And till how long do you monitor? You see LH has come up to 24. Next day you do to see whether progesterone rise, but you find LH has gone to 89. So that day is of the LH surge, and generally progesterone should be around 1, lurking around that or little less. And next to that day, you'll find the progesterone has gone over 1. That is the day which we count as OCR day. And depending on that, transfer at embryo age with progesterone rise. So the day progesterone rises, you start counting that as day 1, 2, 3, 4, 5, and then all day 5, day 6 blastocysts are to be transferred next day to that 5-day period. If you've seen the LH surge and you want to calculate from LH surge, please make sure that it is really the surge, because there could be a 20, 22 or 24 level on, say, the 12th day, and 13th day it may go up to 70. That is a real surge. And next to that day, you should get a progesterone rise. And if it is so, we transfer from the LH surge, the higher surge, 6 days plus, and again, when you see progesterone, it will be 5 days plus. Or what you can do, you don't want so much monitoring. You've just seen that a follicle has become more than 14 millimeter and endometrial thickness looks good, 7-8 millimeter. We can give a HCG trigger then only, before the LH surge starts also. However, if you give a HCG trigger even after the LH surge has started, there's no harm to the cycle. But you give a HCG trigger once the follicle is more than 14, because we don't need the follicle. We needed the estrogen to build up the endometrium. We feel that this endometrium is okay. You can give a trigger at 15 mm, 16 mm, 17 mm, so that we can let the HCG trigger lead to a similar surge like LH, and all the ovulation events happen and progesterone rises. Transfer generally is done on 7th day of trigger, but ensure that progesterone has risen after 48 hours of trigger. Now here, I'll just add one little thing. We give no other medicine apart from folic acid. However, once the progesterone rise endogenous has started, you can add some progesterone as exogenous source also for your own satisfaction. That progesterone level should be good. But if you go on monitoring the endogenous progesterone, most cycles you'll see progesterone flies high in these cycles. It goes up to 16, 17, 18 also before a transfer is there. But generally, it is more than 8. So it is optional whether you want to add progesterone or not. Stimulated cycle with ovulation inducers, you can use any of these drugs. Don't think clomiphene is a no-no. Tamoxifen, letrozole, clomiphene, and gonadotropins, in which a lot of studies have shown that gonadotropins are really good in making a good endometrium, but all the others also make a good endometrium. The monitoring is the same way as in natural cycle. And when do we do these stimulated cycles? In patients who have oligoovulation. They could be PCOS women, or they could be going towards POI and the woman gets her periods in 35, 40 days. Or we find that we gave her exogenous hormones, that is estrogen, but the endometrium just fails to grow. In a natural cycle, it grew to 7, 8, 9 millimeter. And after giving her exogenous estrogen, it is day 20, day 25, and the endometrium is hardly 6 or 7. Here, probably the receptors do not take up the exogenous estrogen so well. Plus, there is a lot of degradation of this oral estrogen when we give it orally to the patient. So let us see what are the best ways of giving hormone replacement treatment cycle for endometrial preparation in frozen thaw embryo cycles. How do we plan frozen embryo transfer cycle? You call the patient on day 2 of a withdrawal, whether it is OCP withdrawal or a progesterone withdrawal, and you do a baseline endometrial thickness, and you see the estrogen progesterone baseline. LH is not important here because we are not going to look at a LH surge later on. How do you do the monitoring? You just go on giving the patient estrogen right from day 2 onwards, and you can call her straight away on day 14, 15. Just give the patient one instruction: don't stop the estrogen whenever you want to come. If you want to come later than I've called you, you can come, but continue the estrogen. If you come earlier, bring your afternoon tablet with you. And then once you find that, oh, this endometrium is looking okay, progesterone has to be started. Now, progesterone is very important because once you start progesterone, you cannot change the embryo transfer date. So you start progesterone according to a transfer date, which is most convenient to you, most comfortable. Avoid holidays, avoid Sundays, but it has to be equal to embryo age. Day 3, day 5, day 5 and 6, always it is 5 days of progesterone followed by transfer, whether it is day 5 or 6. Day 3, it is 3 days of progesterone followed by transfer. What is the available estrogen formulations in India? One is oral, which can be used vaginally also. And especially estradiol valerate has given good results using vaginally. And there is transdermal estrogen as gels and creams. Nowadays, the gel is more available. I have not seen the cream in the market of late. Skin patches are not really available in India, but they are very prevalent outside our country. And that is because in India, it's a hot climate and the skin patches are put on the inner side of the thigh, which is always very sweaty in a hot climate, and the patches tend to peel off. Now, oral estrogens. What happens when a woman takes oral estrogen? And I'm telling you why your estrogen doesn't give the endometrial thickness. It undergoes hepatic first pass metabolism. Higher doses needed to sustain therapeutic blood levels because there is liver metabolism and there could be extensive gut degradation of the drug. So both these things tell us how much drug will really reach the endometrium. Once metabolized, once it is metabolized, estradiol converts into weaker estrogen, which is estrone and estriol with less estrogenic activity. And apart from this, oral estrogen increases hepatic production of thyroxine binding globulin, corticosteroid binding globulin, and sex hormone binding globulin. And the moment this increases, the free available estrogen becomes less. It also increases the triglycerides and cholesterol and clotting factors. What does transdermal estrogen do? It avoids the first pass effect. There is no degradation in the gut as happens to the oral tablet. The first pass effect of the liver is also avoided. Transdermal delivery offers new levels of safety to administration of replacement estradiol, more consistent serum estradiol concentrations without high physiological levels in the liver occur by the transdermal route due to bypassing the hepatic metabolism. Now, if we see transdermal versus oral estrogen, oral estrogen takes 5 seconds to swallow. It's very convenient to the patient, whereas transdermal takes 5 minutes to be applied each time the patient sits down to apply this. So tell the patient that sit down in peace and apply it. Don't just apply it and run away in 10 seconds. Transdermal estrogen systems deliver directly into women's microcirculation in the exact molecular form of estrogen secreted by the ovary without being transformed in the liver into weaker estrogens like estrone and estriol. Oral estrogens go directly to the liver, increase production of hepatic binding globulin, triglycerides, cholesterol, as I told you, and their production is only minimally increased by transdermal estrogen administration. So the triglycerides, cholesterol, and clotting factors, those patients who have a problem about this, transdermal estrogen is so much more preferred because these liver products are not increased by transdermal estrogen administration. Having said that, transdermal preparations are metabolically safer than oral estrogens. A meta-analysis of 15 studies shows that oral estrogen is associated with an increased risk of venous thromboembolism, DVT, and stroke when compared to transdermal estrogen. And this is taken from menopausal women where they get either oral estrogen or a transdermal. And it has less adverse effects on clotting factors, blood pressure, triglycerides, CRP, and sex hormone thyroid binding globulin. Now, estrogel is one which is very prevalent. Estrogel Gen cream was available earlier. I don't know, I've not seen it off late, but estrogel is 17-beta estradiol gel. And all what we need to know is that it is available in a pump pack of 80 grams, and each pump actuation will deliver 0.75 milligram of estradiol, which is contained in 1.25 gram of gel. So 80 gram will at least give us about 60 accentuation pumps. And every pump will deliver us 0.75. Oral, we give 2 milligrams. Here, 0.75 might equate oral 2 milligrams because oral will undergo first gut degradation and then liver metabolism and change into weaker estradiols, whereas this will remain as estradiol into the microcirculation of the patient. I must tell you the method of administration. It should be applied to a clean, dry, intact area of skin where the skin is softer, arms and shoulders, inner thighs, or lower abdomen. So arm also is good. The outer arm, the inner arm, outer arm and shoulders. The area of application should be large, as at least 750 cubic centimeters. How much area would be 750 cubic centimeters in centimeters? About 25 centimeters, right? Or maybe even less. 25 centimeters means 10 inches. So 10-inch area, we need to spread it, or maybe in a lesser area. Every actuation of Estrogel from the dispenser should directly be applied to the area by patient herself. Don't let her take it in her palm or hand and then apply it there like creams. If the pump can be put directly to the area where she is going to apply it, then just let it spread with one finger alone, because this skin of the finger is very thick. No drug will get absorbed here. But if she spreads it with one finger, it takes 5 minutes. It needs to be spread on a large area till it dries up. That means all of it has gone into the skin before you pull up the clothing over the skin. It should not be applied on or near breast or vulva. So how do we prepare endometrium for FET in women with functioning gonadotropin responsive ovaries? Now, she's ovulating also, whether it's irregular or regular, doesn't matter. But when we give HRT, we have two methods. One is you start estrogen tablet or gel, whatever, from day 2 or 3 of cycle in full doses. Why do you give full doses? Because you need to give negative feedback to the pituitary so that it does not start ovulating. On the other hand, on one side you're giving this, and on the other side the follicle is selected and it is progressing towards ovulation. So this should not happen. And for this not happening, we have to give a full dose of estrogen to be able to suppress the pituitary gonadotropin. Or we have another method where you see that despite giving this, the follicle is escaping. That means the estrogen which you are giving is getting degraded a lot in the gut and being metabolized in the liver. So the levels are very low. In such cases, you can down-regulate endogenous gonadotropin by GnRH agonist starting from day 21 or just one single injection of the depot in the previous cycle, and then start estrogen from day 2 or 3 of cycle in a more physiological way from low to higher doses. Here, the risk of the FSH rising will not be there for the next 20 days. And hence, you can go with lower doses of estrogen going to higher doses, and you are not afraid that FSH will be released and ovulation will happen. So first method, only estrogen, estradiol oral or estrogel in non-down-regulated cycles from day 2 or 3 of menses in full doses. Serum E2 progesterone ultrasound, start estradiol 2 milligram or estrogen gel in full doses of 2.5 gram. That means 2 accentuations 3 times a day to down-regulate the pituitary by negative feedback by estrogen going up from here. So my normal thing is 7 a.m., 3 p.m., 11 p.m. And I have treated a lot of patients only on the gel without using any oral estrogen, especially those who feel nauseous, acidic with oral estrogen, and those who do not make the endometrium on oral. I give only estrogen gel. The second method is with the depot or the daily GnRH agonist. You give that, down-regulate, and after that, once down-regulation has been achieved, periods have come, on day 1 or 2 of a subsequent cycle, when you are going to prepare her for FET, you can start the dose of estradiol 2 milligram daily, once daily for 5 days, then twice daily for 4 days, and then 3 times daily for 4 more days. And in generally 14, 15 days, if the estradiol is not being degraded very heavily in the gut, she will make her endometrium. Or you use dermal gel the same way that you use 2 pumps for 5 days and then 4 pumps for another 4 days, and then 6 accentuations for the next days, as long as the endometrium becomes your desired endometrial thickness of 7 or 8 millimeter. Then once you reach that level, whether it is in 14 days, 20 days, or 30 days, or 40 days, don't care about it. But you start progesterone. Before starting progesterone, please do not forget to do one serum progesterone to know whether her ovulation has escaped or not. It happens very rarely with GnRH agonist being given as pre-treatment, but still it is wise to do a progesterone. So estrogen can be exposed to as many number of days, but progesterone exposure has to be equal to the embryo age. So if day 2 embryo is there, after 2 days, day 3, day 5, luteal support, the recipient has no corpus luteum here. So it is pertinent to continue to give progesterone, which is required until approximately 10 weeks of gestation. Placenta starts functioning somewhere around 7-8 weeks. So just to be cautious, you can cover up that area with extra progesterone. Now, I'm showing you a study, administration of estrogen by different delivery routes in frozen thaw embryo transfer cycles. Objective was to compare the influence of different delivery routes of estrogen therapy in frozen thawed embryo transfer cycles. And a total of 244 patients underwent HRT for FET. 2 groups were made. One group of 120 patients used 17 beta estradiol gel by transdermal route, and 124 patients used oral route of estrogen. There were no statistical difference in mean endometrial thickness. Estradiol levels were significantly higher and drug consumption was significantly lower in the transdermal group. Cancellation rate of transdermal group was significantly lower. The biochemical pregnancy rate and clinical pregnancy rates were higher. Abortion rates were lower in the transdermal group, but there was no statistical difference between the two groups. Conclusion was the transdermal route is an effective method for patients using hormone replacement treatment for frozen embryo transfer. My personal experience has been I have used as a sole source of estrogen for FET cycles and continue till 8 weeks of pregnancy. There are no gastric side effects or estrogen effects of estrogen in early pregnancy. Here, I will bring you a small change which I have done. The moment I start progesterone in these cycles, I reduce the dose of estrogen like happens in the physiological ovulatory cycle. I bring the tablet to 2 times or the gel also to 2 times. And then after that, at 7 or 8 weeks, I stop estrogens completely. Mostly use non-GnRH agonist cycle with a standard dose of 2 accentuations of estrogel 3 times a day. But if I find that the ovulation did get released, then I have to cancel the cycle and I go on to a GnRH agonist cycle for the next one. Serves as a good combination with oral estradiol when it fails to achieve desired endometrial thickness on oral route alone. So when I give oral estradiol and I find after 14 days the endometrium has not built up, I start giving transdermal, and I've also changed the oral to vaginal when I see, because vaginal again prevents the liver bypass, the degradation which happens in the gastric area. So if we give vaginal, then it is again goes into the microcirculation, into the lymphatics and direct pass effect to the uterus, like a progesterone tablet. And hence it really works well, these oral tablets when given vaginal. And this I learned from one of the girls who was my student in my master classes only. And I started using vaginal, only the estradiol valerate, and it really, in some patients, gave very good results. Patients who do not tolerate oral estrogen in early pregnancy following FET cycle change over to 4 to 6 actuations daily till 8 weeks. As HRT in young women, 1.5 milligram a day. That means 2 accentuations with hypo and primary ovarian failure, especially for girls who don't tolerate oral estrogen. I would now not give oral estrogen to any of these girls. I just tell them just take 2 pumps of estrogen, maybe 1 in the morning, 1 in the night. Don't forget, so that you have a continuous estrogen supply into your circulation and your bones and vaginal and urogenital health is maintained. Thank you very much. Half an hour we've finished, so we have ample time for question answers.
Yes, ma'am. I think it's so comprehensively you've covered the topics with all the basics, ma'am. You are training a generation of reproductive medicine specialists and practicing gynecologists, and it is a legacy that you are leaving behind with these masterclasses. Really blessed to have to listen to your lectures, ma'am. We'll quickly take up the questions.
I cannot find the chat. Okay,
it's in the chat. Ma'am, what is a natural proliferative phase FET? Dr. Priya is asking this question.
Okay, I can just make it chat. I found the chats now. Okay. Where is the chat gone? What did you ask again?
What is natural proliferative phase FET?
What is natural proliferative phase FET means what? I couldn't understand, Priya.
I couldn't get this question. Dr. Priya,
Can you
if you could
explain
unmute
better?
and ask the question again. Dr. Priya, can you hear us? Ma'am, till then, should we move to the next
Megha
question?
Hussain, for
Or
how many?
how many days do we have to wait to say that now ET will not increase in size and at the highest dose of estrogen? And when should we cancel the cycle?
There is no such boundary. And sometimes in those girls who were hypo, they were just on estrogen replacement, and I took them whenever they came. So you can wait for maybe 2 months at the most. Most of the studies say 50 days, 60 days also you can go. But you have to understand that, something is not right either with the medicine or with the gastric degradation or with the liver metabolism. So change the source of giving your estrogen. Maybe give estrogen valerate vaginally, or you can start using the gel, and I'm sure you will find a difference. And if nothing works, then you cancel it. If you've already given the medicine for, I think, 40 days, 30 days also, we've canceled cycles. It becomes too
We
much
have
for the patient.
given up to 35 days also.
Yeah.
And if it is stagnant, remains the same for about a week, it's not growing at all,
Yeah.
then probably we can decide to
Yeah,
cancel.
if it becomes stagnant, you go on giving for 7 more days and you find it's still 5.3 or something.
Right, ma'am. Should we do estrogen levels on the day we start progesterone? And is there a minimum particular level of estradiol?
Dr. Manoj, we were discussing this today morning while I was coming in the car to my clinic. One of my colleagues asked me that, there are so many people who do this. There are 1 or 2 articles which came on estrogen levels, but really it has no relevance. It has no relevance as long as the endometrium is good and there is no progesterone in the circulation. You don't need to do estrogen levels, according to my knowledge, as far as my knowledge goes.
Dr.
Anything
Priya,
anyone else wants to comment on this? There are studies which have come up. I've read those studies, but we don't look at any minimal estrogen levels.
even if at good levels, if I understand correctly, ma'am, even if the blood levels are good and the receptors are already occupied, the endometrium won't grow even with good levels of estradiol.
Yeah. So levels
So,
really don't matter. The endometrial thickness matters. Uh, yeah.
Is there any minimum number of days of estradiol before starting progesterone? Minimum number, I think we have
I don't think some articles say it should be 11 as less, and no one will. So you can try and give it for 11 days. Generally, everyone takes it for 10, 11 days.
Minimum mentioned thickness is up to, minimum mentioned days is up to 7 days where people have studied.
Okay. I have not really read any article about this, that minimum days, but maximum can be any days. So once your endometrium has become appropriate, I mean, even if it is normal on 7 days, you can give estrogen for another 3 days to satisfy your own receptors that yes, it is 11 days of replacement.
Ma'am, please give tips to manage persistent fluid in the endometrial cavity, excluding eosinophil and hydrosalpinx.
This is a very important question which you've said. There is a clipped hydrosalpinx and there is no isthmocele. Persistent fluid in the endometrial cavity is generally due to 2 reasons. One, at the height of estrogen activity, some secretion can happen in the cavity. Number 2, there could be an element of endometritis somewhere, which is leading to more secretion of fluid in the cavity. For such patients, we generally give them 1 course of antibiotic for 2 weeks, doxycycline or something like that. If still the fluid persists, and it is very little, then you can even transfer your embryo or aspirate that before transfer. Nothing comes. You see it on the ultrasound, but it's like 1 drop fluid, which shows on the ultrasound. So you can either ignore it or aspirate it or treat it with antibiotics and see whether it starts disappearing or not.
Ma'am, should we always be doing estrogen and progesterone levels on day 2 before starting HRT cycles?
Well, estrogen is not so important, I think, on day 2 when you're starting a HRT cycle, but sometimes we've been taken aback by seeing estrogen levels of 200, 300 on day 2. And then if estrogen is so high, then the receptors are all occupied. Your response will be quite poor. And hence, it is good to do estrogen progesterone. I think it is good, but you all can read more. And if you come out with something which says that no, estrogen doesn't matter, however high it is, your estrogen will work. I feel that you don't do estrogen if you are using dermal or vaginal estrogen. Probably that would be a better option, but I like to do estrogen and progesterone on day 2 or 3 or 4 whenever in HRT cycles. Progesterone is a must because if progesterone is more than 1.5 or 2, then we feel that endometrium has some progesterone in circulation and we don't want this in the first half of the cycle. What do you say, Tejashri? Bhavani?
Yeah, on day 2, if it is high, we can still wait for 2 more days and see if the entire withdrawal hasn't happened. We can repeat it on day 4 or 5 to see if it has come down and then probably start after confirmation.
Suppose it doesn't come down, it is 250. We've seen this level. So would you want to start HRT still? We can start, I think, if the endometrium is 3-4 millimeter. What is everyone's opinion? Bhavani?
Ma'am, I feel, ma'am, sometimes post OCR when we plan an HRT-FET baseline progesterone is slightly high, then we can start HRT, but we can check the progesterone again after giving estrogen treatment, and just before starting progesterone, we can check the progesterone level again.
Yeah, that is very important to check that. But all we are talking about is that if estrogen level is, say, 200 or 250. You remember that day in OCRs, I took out case sheets and I was looking at all the case sheets where estrogen level was higher. Then in 2 months or 1 month, we found 11 patients where estrogen levels were higher on day 2. Now, that was either because they had received Progenova before as pre-treatment. There were few patients where estrogen was higher naturally also. So here in FET, does that have any implication? I would want you all to read this and let me know. Put it on the, such nice articles were put over here. Last time I loved the 2 case reports which someone had put, doctor, who had put on the case reports on, what was that last time? I loved those 2 case reports, and then I was sad that why didn't I report my case?
FSH receptor.
FSH receptor resistance. So good. So you all look into this and see that if we start a FET cycle with oral estrogen or with the transdermal gel, can we go ahead and still build the endometrium? And if you can build the endometrium, ignore everything.
Ma'am, the estradiol levels could be high, but 200 level is too high to start. Maybe there's already a follicle which is sitting there, maybe 12 or 15 mm, but it will not secrete such high level.
Yeah, this is right, Shalini, but you know, that is what Bhavani was saying, that repeat the progesterone. If there's a follicle sitting, then it will also luteinize and start secreting progesterone. So it looks high, but how high is high? I have started stimulations on 100, 150 also. Is that right, Tejashri?
Yes, ma'am, we have done that and we found
started
good
HRT
endometrium
and
high
we
level.
got good endometriums. So you all should look into literature, your cases, analyze and see that if you start on high estrogen, if they make endometrium, then I think it is not important to do a estrogen on day 2 or 3. But progesterone is important. But if high estrogen does make a difference, then I think it is always important to do estrogen and progesterone both on day 2 to know how apt that cycle is for HRT FET.
Right,
Okay.
Ma'am, what is the role of uterine Doppler during FET cycle? And is there a role of adding sildenafil if abnormal?
Ansha, I'm sorry, we don't do Dopplers anymore after we got a few studies, one of our own and other Indian workers also, that whether the blood flow is in zone 1, 2, 3, or 4, if the endometrium has grown well, and especially if it is triple line, we don't need Doppler. So we don't add sildenafil, we don't give drugs, we give very, very few drugs. And I'm so glad that our patients get pregnant and they bless us for this, that they didn't have to take medicines.
Right, ma'am. I think there was a similar question which has come up next. Dr. Priya Thamina wants to know which gives better results, natural FET or modified natural cycle FET?
Depends on how intense monitoring you can do. I feel of late we've been doing natural FET with a spontaneous LH rise, and it has suddenly taken my pregnancy rates much higher. I'm
Right.
very glad
And
about
also because we do Sunday transfers, we are not very restrictive on a Sunday transfer. So we like to do more natural cycles than modified natural. But I think one of our consultants does a lot of modified natural and gets good pregnancy rates.
results there also. So you just give a HCG, you know, the moment you find a follicle is 16, 17, also give a HCG and you get off a Sunday, you get off on a Sunday. We've been following very religiously the LH and progesterone, and so a lot of transfers fall on Sunday.
There was a discussion about
Infusion conference
about natural proliferative phase. If it still didn't get it, ma'am.
No, I'll tell you, Priya, what you understand is a natural ovulatory cycle FET. Do you mean that? Priya, can you unmute yourself? Natural ovulatory cycle FET? Natural
No, ma'am, there was a discussion about this in conference about this natural proliferative phase frozen embryo transfer cycle.
This is the best cycle. This is what we are talking about, that if the patient is ovulating naturally, then you just let the natural proliferative phase go. In fact, the luteal phase can also be natural. It is our own fear that we add a little progesterone after we find that the endogenous progesterone production has started, ovulation has happened. Then we add a little amount of progesterone, like once a day gel every bedtime, or 200 milligrams of progesterone tablet twice a day. It is our fear by which we are adding. If we don't add, I'm sure if we have the himmat of not giving anything, they will still have a good pregnancy rates. Okay, so this is the call of the day, that please go for natural cycle FET rather than HRTFET, which is very convenient because you just go on giving medicines, no monitoring, no blood test, and you see on ultrasound endometrium good, you give progesterone.
நான் சொல்ல ஏன்னா இங்க நம்ம ஊர்ல பார்த்தா ஓல்ட் ஏஜ்னு சொல்லுவாங்க
Dr. Sangeeta, hi.
55 years வந்து ட்ரீட்மெண்ட் பண்ணலாம், அதுக்கு மேல பண்ண முடியாது.
Dr. Sangeeta,
ரிஸ்க் எடுத்தாதான் எதுனா பண்ண முடியும்.
Can you please mute Dr. Sangeeta? What are the indications of luteal
status?
I need this person to be muted.
Dr. Sangeeta, if you can hear us.
Can the administrators mute her, please? Mute. Okay. What are the indications of luteal preparations before FET? So luteal dippo can be given when you feel
அதெல்லாம் தெரியும். நான் 1 year அதுக்கப்புறம் அங்க ஊருக்கு போயிடுவோம். இங்கெல்லாம் செட்டில்
I'm also host, so unable to mute.
Yeah. So luteal dippo, I just told you, Renuka, that when you feel that you giving estrogen from day 2, yet your ovulation is escaping, then it is a good case to give luteal dippo from day 21 of the previous cycle. Say you're preparing a patient, you feel endometrium has grown well, when estrogen HRT, and you want to give progesterone from tomorrow. You do a serum progesterone and you find it is already 2.5. Now here you can give a luteal dippo to this patient, say maybe 3-4 days later, because she's already in the progesterone phase of a cycle, and let her downregulate, let her get her periods, and then you go ahead with HRT, and she will not have spontaneous ovulation in that cycle. Maximum dose and duration. Akshay Kumar, maximum dose is 6 milligram of oral estrogen, never more than that, because liver is the one which gets the brunt of this oral estrogen. But you can add other sources where you have direct drug delivery to the microcirculatory system, like patches or vaginal. Is oral form tablets of 17 beta estradiol available? Yes. Nikita, Nova is this only. 17 beta estradiol is there. That's a valerate. Then hemisuccinate is there in that other Endofert H.
There is the next question. Next question is coming whether you prefer valerate or hemihydrate.
See, I prefer valerate always, but nowadays I'm not getting effect of valerate, and I feel that maybe there is duplicate of valerate in the market where the tablet doesn't contain 2 milligrams. So I've started using hemihydrate. It's not very popular, so a duplicate probably has not come yet. But estradiol valerate is effective in whatever doses it has vaginally, because vaginally very small dose is required for the microcirculation to get it. So I ideally would have preferred estradiol valerate, but I'm using hemihydrate a lot.
Ma'am, for a downregulated FET cycle, if Lupride 3.75 injection is given on day 2 of the previous cycle, can we start estrogen valerate from day 21?
No, you have to go
Okay,
the other way around. Give Lupride on day 21 and start estradiol valerate from
You
day.
have to give it on day 21 and start.
Yeah.
Is there a
No, she will
difference
be
between-
down-regulated, true. She will have a menstrual bleed in between, for sure. She will have a menstrual bleed on day 12 or 13 of taking this injection. You can either start it then, after the menstrual bleed, after assessing a hormone's endometrium, or you reverse your sequence.
Ma'am, Shalini, I
Yeah.
have done this like giving Lupride depot on day 2, day 3, and then
Yeah.
starting estrogen on day 23 or 24. It works well.
Yeah,
Because
it should
somehow-
work. If you get the
Yeah.
menstruation and the endometrium is shed, you
Yeah.
can start it.
No,
Definitely.
because if we are giving the depot on day 2, day 3, the endometrium is already shed. That's a different thing. At times, there is a
No, but
bleeding.
it will flare up first 3-4
will
days. It
flare
will
up and there will be endometrium formation in
There
that.
will be a cyst or a follicle formation over there. So
Yes,
you
ma'am.
are lucky that there was no, the flare effect was not very pronounced. After the
Yeah.
flare, it will down regulate in the next 10 days. So after 14 days, you could get menstruation in 15 days, 18 days, 20 days, like you got.
Yeah.
That is the time when you can start. Yes, you can do that. But you
Hmm.
have to understand day 2, you will let the flare happen and then only the down regulation will start.
Yes, ma'am. So that is why we wait long. That is why the effect after the flare, the suppressive effect will come. And that is why we start after maybe
But
like
then,
10 days,
Shalini,
20
madam, what
days.
will happen is that the GnRH agonist effect is 28-30 days. If you
Right.
start it on day 20-23, for the first 7 days, it will be suppressed. After that, it will start releasing, but by that time, the estrogen should take its effect on in sort
Yeah.
of regulating the FSH. It will work, but
Yeah.
you don't have the down
The
regulation right
benefit of
till the
GnRH
progesterone
agonist will be gone
Yeah.
away.
will
Yeah.
be gone away. Yeah.
What
Yes,
to
yes.
do in the cycles if there is ovarian cyst on day 2?
Do nothing. If the hormones are okay, endometrium is okay, just ignore the cyst.
For subendometrial color flow, I think
Don't
ma'am, you've
look. We
already
don't
answered. What do you do? Why do you cancel the cycle if there is escape of follicle in HRT? Can't it be taken as a source of estrogen?
No, escape of follicle can be taken as if the progesterone has not risen. When do you realize that there is a escape is a follicle forms? A lot of times our ultrasound reports that yes, there's a nice 17 mm follicle. If we are giving estrogen and a follicle forms and there is no progesterone, you can absolutely use it as a natural cycle. See, you give HCG and if the progesterone rises in 48 hours, excellent.
Have
Excellent.
even done other way around, converted a natural into HRT as
Cycle
well.
into HRT, say no follicle forms in a natural till day 12, day 15, and you see that the endometrium is sitting low, the estrogen has not risen, then we convert it into HRT also. Whichever way you can do, you can convert one into the other depending on the circumstances. It's just an interplay of hormones.
Any specific pre-treatment in endometriosis cases? I think this is in reference to FET cycle.
Yeah,
Not
yeah.
sure.
No special pre-treatment in FET also. Yes, one thing we can do, if the volume of the uterus is very high due to adenomyosis, then maybe it is a good option to decrease the volume of the uterus to a more reasonable level, say 100 cubic centimeters, and then do a transfer. So that may require long down regulation with GnRH agonist, maybe 6 months, maybe more. Endometriosis, we don't need to downregulate, but a lot of people feel that even downregulating endometrioma is a good thing before FET. So you can probably downregulate it for 3 months or 4 months, but not less than that.
And we'll try to take as many questions as possible. 10 minutes left, and we still have 13 questions probably.
I have a patient
Ma'am,
with what is it?
28-year-old FET, started with HRT, endometrium was 6. And once I've given tablet letrozole 5 milligram for 5 days and HMG 150 for 4 days, dominant follicle of 12.5, and not increasing more than that, but the endometrium came to be 8.2.
Oh, very
So in
good.
HRT
You're very
cycle, she
lucky.
had less. Very nice. Yeah, this is good.
But did she start with 6 mm endometrium?
No, so in HRT cycle, it came to be 6 mm. That's what she means, I think.
And when you gave
in a
letrozole,
stimulated cycle, the endometrium got
this is
better.
the difference between a stimulated or natural cycle and HRT cycle. HRT, the medicine gets totally disintegrated in the gut for a lot of people. And in the liver, it's metabolized into weaker estrogens. So this is so good. Let the follicle be 12.5, give her a trigger. HCG de do. Or dekho, if the progesterone rises, very good. If it doesn't rise, give her progesterone and give her a small dose of estrogen to continue in the luteal phase. What do you say, Bhavani, Tejashri?
Ma'am, we can even continue a little more HMG and let it grow to 14 mm and then give a trigger.
Yeah, definitely. You can continue more HMG. This is a good
And
suggestion.
ma'am, we had that study where we had seen the thickness of endometrium maximum. How much can we go? For
It can go up to
success
16,
rate wasn't
17.
affected by the thickness of
So
endometrium.
what
Up to
Dr.
16 mm.
Tejashri is saying, give her more HMG and dominant, but you've written 12.5 mm dominant follicle seen and not increasing more than that.
So I think her concern is that the endometrium is already 8.2.
Endometrium 8.2. Nupur Bajpayee, will you talk out? Nupur Bajpayee, are you there? So what I feel is that you can give more HMG for a few more days, and once the follicle crosses 14 millimeter, you can give her a HCG trigger and then do the progesterone levels after 48 hours and transfer accordingly.
Ma'am, if the ovaries are silent on day 2, even then should we do E2 and progesterone levels?
I think I like to do, Manoj, I understand that this is the second time you're asking the same question, and it may be difficult to do the hormones. You may not do any hormones. If the ovaries are silent, endometrium is thin, you can just go ahead with the HRT cycle. We are very afraid of progesterone. That's why we do it.
Ma'am, one of my patients on HRT protocol, Dr. Nisha is asking, after 21 days, her lining was 8.5 triple line, started on progesterone, but on the day of transfer, there was fluid. So I had to cancel. What could be the
People
reason?
cancel on drop of a hat. People cancel if the blood flow is not good in the endometrium. People cancel if there's fluid. People cancel on everything. The progesterone, I'll tell you, yesterday I had a pregnancy positive of a patient, and Bhavani would know the name. She had a progesterone of 1.2 on the day of FET. 1.2 HRTFET. She had 6 IVF failures in various places, Mumbai and Delhi. And she was crying her heart out because my colleagues put her on an injectable Equisustain, on the fear that this is so low. How beautifully she got pregnant. Her HCG levels were like 1,000. And she got pregnant. So progesterone levels, don't cancel your cycle if the progesterone is less than 8. Don't cancel your cycle if there's minimal fluid. You can always aspirate the fluid. Yes, if you think that you've missed out chronic endometritis, she's had previous miscarriages or interference in the cavity, then you can cancel and give her a course of doxycycline. My preferred route of progesterone is only vaginal. I don't use anything. Injections I give because my colleagues press me to do it. My younger colleagues press me to give that. No, ma'am, give. But this girl, I mean, she asked me yesterday, should I continue with this injection? I said, I don't know. Now you're taking it and you got pregnant after 6 failed transfers. This is the first cycle she underwent with us. And she blessed me for not giving her any medicine. She was just on folic acid and this blessed injection with a vaginal tablet. So these are very
Ma'am,
painful.
what is, right, what is your rule on atosiban infusion?
I've never used. I'm sure. Shalini, you tell us.
So haven't used.
I-
I haven't used it, ma'am, at Osiban.
Anyone has used can talk about it. I haven't ever used it. Chitra says when E2 is about 150 on day 2,
What
what
will be
would
the
be your choice? For stimulation, I would want to give HRT in such cases because stimulation may not give me very good results.
Should we need to check the P4 levels before ET, and what is the cutoff in both natural and HRT?
See, before ET, a lot of studies have come out on P4 levels, and people feel that if P4 levels are more than 8 nanograms, that's a good cycle. But in lower, also, I just told you yesterday on the day of ET, it was 1.2. I mean, the lowest ever you could think of. And our analysis, which Dr. Bhavani did, is Bhavani there? What was the lowest E2? In which we did not, P4, sorry, in which we did not give any support and yet got a term pregnancy? Bhavani?
Ma'am, 2.5 nanogram.
2.5, and I did not give her any support. I'm very, very conservative about prescribing medicines to patients. Is it possible to get a recording of this? Yes, it is possible. It will come on my
I think,
the YouTube handle or my website.
ma'am,
Yeah.
ma'am, regarding the P4 levels, I think the blood levels may not reflect the uterine levels of
Very
P4.
correct.
And that's
We
what is
use
the,
vaginal, you know. So the blood levels don't reflect, and that is why lower levels lead to term pregnancies without any support.
with 12 mm cyst and E270, but normal P4 on day 2, what to do?
My goodness,
We
there's so many
can
questions more.
just, I know, 3 more
Yeah,
questions to move. And there is one question about endometrial scratch, ma'am, if you would like to talk on that.
No, I mean, this is in RIF, not in
Mm.
regular FET cycles. And somebody has written, is there any role of adding exogenous estrogen with modified natural cycle FET if it is still thin in spite of good size of follicle? Absolutely no. Capital N and capital O. Whatever forms with a good follicle and good estrogen levels made endogenously, don't add anything. Your embryo will implant in an endometrium which is less than 7. It could be 6, it could be 5. Also, it will implant if it's a clean cavity and there's no disease inside.
When we are doing a natural cycle, adding exogenous estradiol will only hamper the LH search. And also it will not be helpful because the follicle receptors are already saturated with estrogen, the endometrial receptors.
Yes. So
Do
chocolate
we have
says
down
die how to get FET in this patient. You can give her some GnRH agonist for 2-3 cycles, let the cyst subside, let her pain go away, and then do a FET cycle with
HRT cycle?
HRT, that also use gel or use vaginal tablets.
On the day of FET, day 5, in spite of giving IM progesterone and intravaginal 300 TDS, progesterone level was 8.4. What could be the reason?
No, I'm very happy it was 8.4. Why are you getting bothered about more? Please, there is nothing as more. Even I would have been happy if the progesterone was 5 and 6 also. So please be happy with the patient's progesterone, whatever it is.
Ma'am, in modified natural cycle, do you always advise to do a progesterone after 36 to 48 hours after HCG trigger?
Where to do progesterone after? Yes. Yes, sometimes HCG is pani. It is not HCG and nothing happens. Now, I saw a question, Nisha. Ma'am, do you check progesterone levels? हमने अपनी उंगलियां जला के सीखा है ये. We were not checking. We were like, aha, HRT cycle, progesterone will not rise. And we did 2 ERA tests, and every ERA would say post-receptive, 4 days, post-receptive, then 3 days, post-receptive. I called up the ERA people and I said, I can't give progesterone for less than 3 days to do a blastocyst transfer. What is the reason of it being post-receptive? They said, did you check up progesterone before starting progesterone? I said, no. Before starting the exogenous progesterone? I said, no. And when we checked, it was as high as 8 nanogram, right, Tejashree? in both the
Yes, ma'am.
patients. It was 8 or 6 in both the patients. So
Right.
it is very important to check progesterone, and if it is high, cancel the cycle. I think we have had enough questions.
Yeah.
We can do
So we
Pooja.
can do more questions on the WhatsApp group. If anybody
Yeah.
has more questions regarding this, they are welcome on
And
the
Rhythm
WhatsApp.
had put a question which Tejashree had answered. What
I
question?
didn't answer. I just asked her whether this AMH
She
was
will
current.
recover. OC pills can suppress a ovary quite significantly after 3 years of continuous use. Give her 2-3 months Rhythm, and it will.
Yeah, if the FSH, LH, and AMH are normal, then we don't need to.
Yeah,
worry
then we don't
about
need
it.
to get worked up.
Thank you so
All
much,
right.
Abha ma'am. And from all of us, all the attendees today, we had almost 100 people joining the class. And that shows how followed you are and how popular and how
I don't want to
we
be
are all-
followed and popular. I want to learn from these
we are
classes.
learning
And
from you.
there were 2 or 3 questions which I was not sure about. I would want you all to put references for them. The E2 levels, like before starting progesterone. Then atosiban. I have a lot of studies, and I don't think atosiban is a good compound to give. What do you think, Tejashree?
Right, ma'am. I think we need to do more studies on it to be convinced to use it. In patients also, it's very expensive. So thank you so much for
All
joining,
right.
everyone.
Thank you, Vishal. Thank you, Intas, for giving me this opportunity to teach. I love to teach, and I think
Thank
that
you.
every teaching gives me a better clarity on my work also. So it helps the work standard. Thank you so much. Thank you.
Support team, please end the meeting.
Sure, sir. Good night.
Good night.